Good afternoon, everyone. Thank you for joining Nova Signal's webinar on Mastering M Mode for Improved Efficiency. My name is Jeff Mahan, and I'm a Senior Clinical Education Specialist here at Nova Signal. This course will provide you with a basic understanding of Power M Mode for greater accuracy and efficiency. Our technology we use to perform a transcranial Doppler exam is demonstrated on the right here. It's our NG2 robotic transcranial Doppler system. In today's presentation, we will cover the anatomy of the intracranial and extracranial arteries as listed below, the MCAs, the ACAs, the terminal internal carotid arteries, the posterior cerebral arteries, the vertebral arteries, the basilar artery, the siphon arteries, the ophthalmic arteries, and the extracranial internal carotid arteries. Power M mode plots 64 millimeters of depth using the amplitude and direction of flow by overlapping 33 Doppler sample gates. The MCA is represented in red here as blood flow towards the transducer, and that is a red band within the Power M mode. The ACA flows away from the transducer, flow away from the probe in M mode is demonstrated as a blue band. The brightness of the M mode signal corresponds to the amplitude of the signal. The brighter the signal, the more red blood cells being reflected. As such, the amplitude of the M mode is a direct correlation to the quality of the Doppler signal you will get below. The sample volume in this particular case is at a depth of 50. The color representation is very strong and looks very good. The corresponding Doppler signal looks good as well. If we move this depth to the end of the ACA where the blue is getting sketchy, the Doppler signal would become sketchy. The NovaGuide 2 and Lucid systems use 2 MHz probes with digital processing to provide the user with the M mode, which shows the amplitude across depth and time, a graph of the blood flow or the Doppler signal, which shows the speed over time, and it also provides the user with an audible output of the frequency shift, which helps detect subtle changes and embolic events. Power M mode benefits. First and foremost, it aids in window location. Most of us are used to using our ears to identify Doppler signals and find windows transtemporally. Our ears are a very important tool in TCD and should never be ignored. Having said that, Doppler signals and sound only come from the depth the sample volume is placed. So that is one depth along your entire M mode map. As you are trying to find a Doppler signal over a transtemporal window or just find transtemporal windows, it is important to use your eyes and look for color bands at any depth. If you see a color band at any depth as you are searching for a transtemporal window, that means the ultrasound is penetrating the skull and you are over a window. It may not be the vessel that you are trying to insonate, but that means that you should stop at that location and make small angular adjustments to obtain the vessel you are trying to insonate. It also helps with vessel identification. Each vessel in the brain has a certain color pattern within the M mode. It accounts for varying head sizes. The blood vessels within the brain live at different depths and different head sizes. Most of our charts are based on average skull size. As we all know, some patients have very large heads, average heads, small heads. They can also be different shapes. All of these items can affect the depths. The M mode doesn't lie. It just tells you blood flow straight in front of the transducer, no matter the size of the head. It also assists in emboli detection. You can actually see the emboli within the M mode across multiple depths, not just one depth. This is a typical adult schematic showing the typical values, locations, and probe angles for the arteries. I'm not going to cover all of these. I am sure everybody has seen a chart similar to this. the most important part about this slide is that there's a lot of information to remember. M mode makes it so that we do not have to remember all of these depths, as some of the color patterns are pretty standard, and you can just look at the color patterns to identify which vessels you're at. The MCA feeds the bilateral anterior cerebral hemispheres. The MCA has two segments that can be evaluated, the M1 and M2 segments. Blood flow in the M1 segment is flowing towards the transducer, so that will represent itself as a red band. In the M mode, the M2 segment is where the MCA branches. Those branches can come towards or away from the transducer and can be either color. The MCA is the most important vessel to identify over transtemporal windows. It lives at depths between 30 and 60 millimeters, and it must have flow below a depth of 50 millimeters for you to positively identify it as the MCA, as represented here in this M mode pattern. The anterior cerebral artery feeds the midfrontal hemispheres of the brain. Blood flow originates in the internal carotid artery and travels away from the transducer. It is a blue band within the M mode, living at depths of approximately 60 to 75. The anterior cerebral artery is a blue band attached to the MCA. So in all reality, we do not need to remember the depth of the ACA. If you can obtain the MCA and identify it positively as the MCA and slightly angle the transducer at the same time towards the anterior circulation, you should be able to get a red and blue band together. The blue band is the ACA. There cannot be space between this red and blue band. You can't have a big gap. It must be attached. As soon as you represent that on the M mode correctly, that is the MCA and ACA. The bifurcation, this is where the MCA and ACA color bands meet. This is an anatomical location for us. This depth is approximately where the terminal internal carotid artery lives, as well as the PCA lives. Once we are through incubating the MCA and ACA, and we are ready to progress to terminal, we would set the depth where these colors come together and aim the transducer inferiorly. The terminal internal carotid artery provides blood flow to the anterior circulation as well as the posterior communicating artery. Blood flow travels towards the ultrasound probe, so it should be a red band. However, it is possible to incident flow in the TICA going away from the probe if you use a severe inferior angulation. Once we place the sample volume at the bifurcation depth, the terminal internal carotid artery will be a red band, which lives inferior to that bifurcation with no flow below 50. This is a good representation of color pattern recognition. As you can see, part of this band meets MCA criteria. It's almost 50 to 60. It's red, it's towards the transducer, but there is no flow below 50, so this cannot be the MCA. This is the terminal internal carotid artery, as we are aimed inferior to the bifurcation depth, and the M mode demonstrates no flow below 50. The posterior cerebral artery 1 segment, or PCA1, feeds the posterior hemispheres of the brain. Blood flow originates from the vertebral and basilar arteries. Blood flow is traveling towards the ultrasound probe. Therefore, there'll be a red band representing the P1 segment. It is possible to get just a red band by itself, or also this red and blue band, which I will cover later. If it is just a red band by itself, if you notice in M mode, P1 and terminal look the same in M mode. So as you are searching for a transtemporal window, if you see a red band between 60 and 70 with no flow below 50, this is either P1 or TICA. If you're looking for the MCA, your first maneuver is to aim the transducer superior, as both of those vessels live inferior to the MCA. And if that does not obtain the MCA, you also need to aim the transducer anteriorly, because that tells you it was most likely the P1 segment of the PCA. So the PCA segment is a red band that's inferior and posterior to the bifurcation depth with no flow below 50. The P2 segment feeds the posterior hemispheres of the brain as well, and it flows away from the transducer. It's important to note you will never see P1 and P2 segments of the PCA on the same M mode screen. They live in anatomical locations which are different. P2 lives posterior to P1 at the same depth. So once you identify P1, you do not change the depth, you just aim the transducer more posterior and you will get P2. So P2 segment is a blue band which lives inferior and posterior to the bifurcation with no flow below 50, and it also lives more posterior to P1. Both PCAs at midline. M mode shows flow in a straight line. It does not lie, it just tells you the blood flow in front of the transducer. In this particular M mode presentation, the red band is the ipsilateral PCA1 segment and the blue band is the contralateral PCA1 segment. Where the bands meet is actually the top of the basilar artery. And again, PCA1 and PCA2 will never be seen on the same screen. They live in different anatomical planes. So if you can imagine my transducer is above this label, both P1s. As we aim the ultrasound beam in, this is P1. That's the red band coming towards the transducer at a shallower depth. At a deeper depth, as the ultrasound goes straight, this is P1 on the other side of the brain as the contralateral P1, and that is blue, and that's the blue band below. As we look at both PCAs at midline, the PCA1 segment is represented as the blue band, and the Doppler signal, that's the blood flow above the baseline. The contralateral PCA1 segment is the blue band, and that corresponds to the Doppler signal below the baseline. The extracranial internal carotid artery, blood flow is going away from the transducer, and it will produce a blue band. It typically lives at depths of 40 to 60 millimeters. However, it is possible to get this shallower or deeper, depending on where the transducer is located. This should be a very strong, high amplitude signal as we have no bone in the way interfering with the ultrasound. The intracranial vertebral arteries originate from the subclavian arteries. Normally, blood flow is away from the transducer, so it will present as a blue band between 60 and 79 millimeters. So the intracranial vertebral arteries is a blue band between 60 and 79 millimeters. It's important to note when we are evaluating for the basilar artery, there are 3 windows through the back of the head, left, middle, and right. In 75% of us, we are left vertebral artery dominant, so that is the best window to use to insonate the basilar artery most of the time. However, if you use your M mode, you can figure out which window is best based on the M mode. So if we pretend that this is the left vertebral artery, the depth here at 80 and beyond in this vertebral artery M mode is basilar. You can see how well the blue is filling. That would tell you that this is probably the optimal window for the basilar artery. If this is the left and it doesn't look good beyond 80, we move on to our right intracranial vertebral artery. If it presents like this, we know it's the right side. If there is not good flow in either vertebral artery window from left or right beyond 80, that tells you it's the middle window. So use your M mode map to tell you which window is optimal to obtain the basilar artery. The basilar artery is formed by the confluence of the intracranial vertebral arteries. Blood flow is normally away from the transducer, and it's a blue band that lives between 80 and 120 millimeters. It's important to note with your M mode, try to never move the sample gate two regions where the color is not filling well. So for example, in this slide, if I wanted to look at a depth of 75, you can see the color's a little sketchy. Or if I wanted to listen down here at 105, there's essentially no color. Most of us, as we should be, are really focused on sound. In my experience, as the sound gets weaker or as the sound completely disappears, we all tend to start to make bigger movements, almost a sense of panic that we're losing things. So using the M mode to adjust your transducer is quite helpful. For example, if I wanted to listen at 110, I would angle the transducer and not change the sample volume depth until I got blue flow at 110. Then when you move the sample volume there will be sound, and we will not go through that sense of panic and, oh my goodness, I'm going to lose my window. So it helps you stay more focused and stay at the same location. I've mentioned several times already about listening and eyes. It's not that one is more important than the other. Sound is very important. Eyes are very important. You need to use both to improve your accuracy and efficiency. So the basilar artery is a blue band that lives between 80 and 120 millimeters. The ophthalmic artery feeds the orbit. It is the first branch of the internal carotid artery. Blood flow is towards the transducer normally. Most TCD systems have a higher filter setting for our intracranial vessels. As such, the ophthalmic artery will demonstrate an M mode as a red, black, red, black, red, black pattern, so an intermittent red flow as the system is filtering out these very low diastolic velocities in the ophthalmic artery. The ophthalmic artery is much more resistive, lives between depths of 40 and 60. So again, it's an intermittent red band between depths of 40 to 60. This more consistent red band at a deeper depth, that is our carotid siphon. Blood flow in the supraclinoid segment of the carotid siphon is flowing towards the probe. This will produce a red band representing the supraclinoid segment. Typical depths are 65 to 75 millimeters. In the M mode, it'll present at those depths with no flow below 50. This is over the eye. The supraclinoid segment flows towards the transducer. The paracellular segment of the internal carotid artery, which lives more inferior, flows away from the transducer, so the siphon can be a red or blue band between 65 and 75 millimeters. Which one do we take? Usually, whichever color band is the strongest in amplitude is the one that you should insonate. These are vessels that we typically only take one representative signal in, so the stronger signal is going to be the most accurate velocity and the most accurate information. Detecting emboli. The temporal characteristics of emboli help distinguish themselves from artifact. Emboli traveling towards the probe have a positive slope. You can see this emboli within the Doppler spectrum here and is represented here within the power M mode as this bright line, as it is in the next two slides as well. Emboli traveling away from the probe have a positive slope. You can see in this first slide, the emboli actually starts in the terminal internal carotid artery and goes out the ACA, as is the case in the next two slides. What is important to note is where your sample volume is placed. If we do an emboli or bubble study with just Doppler alone, we are only listening at that particular depth. We are not listening across multiple depths. This is the reason power M mode makes detecting emboli or bubbles more accurate, because we are listening across multiple depths. This first slide is a good representation of this. The sample gate is placed in the MCA. You can see the corresponding Doppler signal below. There is no emboli within the signal, and yet there is an emboli that we see going out the ACA. So this is one that you could potentially miss. Now at the farthest slide, we have placed the sample gate in the ACA, so we pick up the emboli in the ACA because we have the sample gate placed there. But if there was an emboli up in the MCA, we would not see it at this point. I appreciate everybody attending today. In summary, try to use your M mode for window location, also in vessel identification. This will definitely improve your accuracy and efficiency by finding windows at a much faster pace, being able to identify vessels quicker, and also improving your Doppler signals based on the intensity of the amplitude of your M mode. This webinar will be placed on our Academy page at www.novasignal.com/academy. I encourage everyone to go to our website and check out the NG2 robotics system, as well as the Academy page to look at previous webinars, upcoming webinars, educational materials we have online, and educational courses that we offer. Have a wonderful rest of your week and have a great day.